In this video of antimicrobial stewardship, we are going to learn about details on components of antimicrobial stewardship. Last video will tell you about the essential elements of antimicrobial stewardship. Prospective audit with feedback and intervention. Audit and intervention are done to optimize drug selection, dose, duration, and route of therapy of all drugs. In a study, the prospective audit with intervention and feedback resulted in 22% decrease in the use of parenteral broad-spectrum antibiotics. They also demonstrated decrease in the rate of Clostridium difficile infection, nosocomial infections caused by drug-resistant Enterobacteriaceae. A Cochrane systematic review and meta-analysis showed reduction in the duration of antibiotic treatment from 11 days to 1.9 days. Next is the formulary restriction and preauthorization. Formulary restriction or preauthorization are an effective method to control antibiotic use and cost, thus decrease in the antimicrobial resistance. A survey of 22 institutions found that those that implemented this program of carbapenem restriction experienced a statistically significant reduction in both carbapenem use and Pseudomonas aeruginosa resistance to carbapenems compared to those institutions that allowed unrestricted use of carbapenems. Disadvantage of this strategy is that they may not be well accepted and ordering physician may attempt to avoid it. Educating the physician on rational use of antibiotics. Education is the most frequently employed intervention and is considered to be an essential element of any program designed to influence prescribing behavior. Antibiotic Stewardship Program should provide regular update on antibiotic prescribing, antibiotic resistance, and infection disease management that addresses both national and local issues. Sharing facility-specific information on antibiotic use is a tool to motivate improved antibiotic prescribing practice. There are many options for providing education on antibiotic use, including presentation, posters, flyers, newsletters, web-based education, or electronic communication to the staff. Optimizing dose and route of administration. Dose optimization takes several factors into account. This includes the pharmacokinetic and pharmacodynamic characteristics, patient characteristics, causative organism, and site of infection. Pharmacokinetic monitoring and adjustment program can reduce cost and decrease adverse effects. It is recommended to implement pharmacokinetic monitoring for aminoglycosides and vancomycin. This dose optimization strategy reduces nephrotoxicity, length of hospital stay, and mortality. Choice of oral or IV therapy will depend on drug level required at the site of infection, the potential for absorption from the GI tract, and the severity of disease processes. De-escalation and decrease in unnecessary combination therapy. The rationale for combination antimicrobial therapy includes broad-spectrum empirical therapy for serious infections, improved clinical outcomes, and the prevention of resistance. However, the available data are insignificant to recommend the routine use of combination therapy to prevent resistance. However, in many situations, combination therapy is unnecessary. Excessively broad spectrum therapy contributes to the selection of antimicrobial resistance pathogens. These conflicts can be resolved when culture results become available, which in turn promote judicious use of antibiotic by streamlining or de-escalating empirical therapy to more targeted therapy that decreases antimicrobial exposure and contains cost. Next is optimizing appropriate duration of antibiotic. While duration optimization helps to avoid automatic 10 to 14 day course of therapy, Following are the new evidences of duration of therapy. First is uncomplicated UTI. The duration of therapy can be 5 days. Community acquired pneumonia, the duration of therapy can be 7 days. Ventilator associated pneumonia can be having 8 days of duration of therapy. Catheter related bloodstream infection, coagulase, negative staphylococci infections can be treated for 7 days. Acute hemosteomyelitis in children can be treated for the duration of 21 days. Meningococcal meningitis have a duration of therapy of 7 days. Uncomplicated secondary peritonitis with source control have a duration of therapy of 7 days. Uncomplicated skin and soft tissue infections have a treatment duration of 5 days. The other core elements of antibiotic stewardship include regular antibiotic use measured by two strategies, that is, days of therapy dot or defined daily dose DDD of the patient during hospital stay. Antimicrobial cycling will refer to the scheduled removal and substitution of a specific antimicrobial or antimicrobial class to prevent or reserve the development of antimicrobial resistance. Antimicrobial order form will decrease antimicrobial consumption through the use of automatic stop order and the requirement of physician justification. Defining the optimal timing and duration of preoperative antimicrobial prophylaxis, use of preoperative prophylactic order form with automatic discontinuation resulted in a decrease in the mean duration of antibiotic prophylaxis.